So this morning, I'm excited to welcome our own Dr. Heidi Brown. Dr. Brown received her undergraduate and medical degrees from Brown University, and then residency in obstetrics and gynecology at the University of Pittsburgh Magee Women's Hospital. After residency, she completed a fellowship in female public medicine and reconstructive surgery at UCSD and Kaiser, during which time she also received a master's in clinical research. She then came here to University of Wisconsin, where she's currently an assistant professor in our division of advanced pelvic surgery. Looking through Dr. Brown's CV, there's so much to say. She's a researcher with incredible funding. She's a prolific writer and collaborator. She serves as an amazing resident and faculty mentor, both for research and clinical practice. Much of her research currently is focusing on continence promotion and community engagement. And I'm very excited to hear her talk today. So please join me in welcoming Dr. Brown this morning.
Thank you so much, Dr. Bizzuto. That was a lovely introduction. I have a few disclosures. Mostly I get royalties from UpToDate. I'm a consultant for a company called Grand Rounds. I do like expert consults on patients for them. And I have a grant from NIDDK to study some stuff related to urinary and fecal incontinence, but I'm not talking about anything that's influenced by those things today. I have 3 educational objectives. So when you fill out the survey later about whether or not the objectives of the talk were met, these are the 3 ones that we're hoping to accomplish. Identifying risk factors for bowel incontinence, describing the initial evaluation and management of bowel incontinence, and understanding the advanced management options for bowel incontinence. And I put this little Bucky Badger sign, and every time we're actually hitting one of those educational objectives, you'll see the little Bucky Badger. So that'll hold me accountable to make sure I hit my objectives. I am not really talking about my research at all today. This is meant to be a talk to aid in clinical practice and talk about something we don't talk much about. So I like to joke when somebody asks me why I study or am passionate about bowel incontinence, that when you're training in a place as beautiful as San Diego, you can be convinced to study just about anything. And that was Mimi Lucas, is the person pictured in the lower left corner, and she's the person who first piqued my interest in this topic. But the real reason why I study bowel incontinence is because it's surprisingly common and much more devastating than urinary incontinence is, and it's treatable. And also, as OBGYNs, if not us, then who? We're the people who tackle the other taboo topics. We ask women about painful sex. We ask women about intimate partner violence. We ask about urinary incontinence. This is really in our wheelhouse. We are the people who should be tackling this taboo topic. So I'll start with some definitions. When I say bowel incontinence, what I mean is the involuntary loss of liquid or solid stool that is a social or hygienic problem. So when a baby poops in a diaper, that's not incontinence. Anal incontinence refers to can be loss of stool or loss of flatus, but bowel or fecal incontinence means like something has to soil your undergarments. And fecal urgency is an associated symptom that's very bothersome but might not result in incontinence. And this is sort of akin to for women who have overactive bladder, where they don't actually leak urine, but they have to run to the bathroom every 30 minutes, and they're really bothered by that. With bowel urgency or fecal urgency, which is defined as the inability to defer defecation for 15 minutes, you can imagine how that can be very bothersome, even if it doesn't result in an episode of incontinence, because you may have to excuse yourself without much warning. But the term I used in the talk title was ABL, or accidental bowel leakage. So what is ABL, and why did I use that instead of fecal incontinence or bowel incontinence? Essentially, ABL is to fecal incontinence as ED is to impotence. It's essentially a synonym that makes it easier to talk about an uncomfortable topic. And the term became popularized about a decade ago. And this was part of the work I did during my fellowship. There was a survey that was done using a Nielsen database, which is like a consumer email database that you can pay money for. And there had been a large survey conducted, and my primary mentor was going to analyze that data, the survey that had already been collected, and she gave it to me and said, why don't you lead this? Why don't you do the data analysis? And so a lot of the data, a lot of the slides that I share in this talk are taken from that survey, which is now, almost a decade old. But essentially, they surveyed about 5,000 women aged 45 and older who were part of this electronic bank of, consumers who would do surveys about, all types of things, like what type of detergent do you use? And this one was about mature women's health. It was called the Mature Women's Health Survey. And about 1,000 women in the sample actually had fecal incontinence. 1,000 of the 5,000 women who responded to this survey about mature women's health actually had fecal incontinence. And when they were asked which of three terms they'd prefer to describe their symptoms, the majority, over 70%, preferred the term accidental bowel leakage. And about a quarter preferred the term bowel incontinence, and only 6% preferred the term fecal incontinence, which is certainly the term that I learned in medical school and that I feel like we as doctors are most comfortable with. And it was sort of an interesting, when we published this paper saying that this was the term, it was very interesting because doctors really don't like to say it. So I don't usually use it with doctors. With doctors, I say bowel incontinence or fecal incontinence. But with patients, I often say, do you have any accidental bowel leakage symptoms? Because that's what the data tell us. But really, it's not so much about a name, right? Call it what you will. It's still a really bothersome problem. And what I try to do when I'm taking a history, and obviously this is, like I talk about this every day I'm in clinic, whatever terms they use to describe their symptoms, I jot down in my note. And then when I see them in follow up, I ask about the same thing. Like, how are the accidents? Have you had any visitors recently? These are literally all terms that patients have used. Dumps might be my favorite. And there are also some that are, considered swear words, so they're not on here. But whatever words patients use to describe their symptoms, I then try to use, just because that's how they think about it, and that makes them feel comfortable to talk about it. And it is really embarrassing to talk about. So if we can make it a little easier by using their words, let's do that. Importantly, it's fecal incontinence or bowel incontinence is really not just a female problem. And I think there's a big misconception that fecal incontinence happens because of obstetric anal sphincter injury or childbirth, and that's how fecal incontinence happens. And actually, that's not true. I mean, we'll talk more about that. Obviously, it's true in some people, but about 8% of US adults aged 20 or older have monthly fecal incontinence, and a little bit higher in women than men, but not statistically significantly different. 8.9% of women, 7.7% of men. These are data that are from the National Health and Nutrition Examination Survey, which is a national population-based health survey. And what we see in NHANES is that the prevalence of fecal incontinence, and this is monthly fecal incontinence, increases with age. And we see that in women, there's sort of this increase as we start to go through menopause, age 40 to 54. And then by the time we get up to age 55 to 69, we're in the 15% prevalence, and that's where we stay. Whereas with men, we see an increase starting in the 30s and a slightly more gradual increase. But again, men and women are at the same place when we're 70 or above. So by menopause, 1 in 6 women has at least monthly fecal incontinence. And the reason why is because of common concomitant disorders associated with fecal incontinence, like disorders of chronic bowel disturbance, things like irritable bowel syndrome, gluten sensitivity, chronic diarrhea, chronic constipation. Urinary incontinence is highly correlated with fecal incontinence. Diabetes is a big risk factor for both urinary and fecal incontinence. Trauma that happens during childbirth is a risk factor, and obesity is a risk factor. And we'll talk more about the relative risk of these various factors. Um, and importantly, while this condition is prevalent, most people have mild symptoms. So this histogram describes the score. The Wexner score is a numeric score from 0 to 20, where 0 is you're completely continent, and 20 is your daily incontinence of liquid, solid, and um, a liquid and solid stool and gas, and you're needing to use constipating medicines, and you're needing to wear pads. And we draw a line depending on which studies you read. We draw a line at 8 or 9 as being severe symptoms, but you can see most people have mild symptoms. So that's good news because it's easier to fix mild symptoms. But importantly, even mild or infrequent symptoms can be really bothersome. So this quote, "Mine is a miserable life," that is what a patient wrote on her the new patient questionnaire that she filled out when she came to see me the first time. That was her chief complaint. "Mine is a miserable life." And this percent here on the left is showing you that of those roughly 1,000 women in the Mature Women's Health Survey who had fecal incontinence, and we included people who had it at least once in the last year. So you didn't even have to have it like monthly. 97% were bothered by their symptoms. Um, and the quality of life is greatly impacted in about 1,000 women and about 900 women who provided these quality of life data. 39% reported a severe impact in one of 7 domains of quality of life that we measure commonly in urogynecology. The most frequently affected domain is feelings of frustration, which was experienced by about a third of women, and then close behind that were emotional health, participation in social activities, and ability to travel 30 minutes or more by car or bus. These are the way that this data is organized. This red line here is 50% of the population. Dark gray means that they'd agreed somewhat or strongly with the statement. Light gray was neutral, and medium gray was disagreeing. So you can see that 50% of women with fecal incontinence agree. And remember, this is people who could have had it just once in the last year, not necessarily like the severe fecal incontinence. 50% agree with the statement, "I fear I'll have an accident in public," and more than 50% wish they could get their normal life back the way it was before they had this condition. And just under half agree with the statement of having good and bad days and it being out of control. And about a third feel like they're fighting a losing battle. So it really is a really impactful condition, even if it doesn't happen commonly. This is a quote from a woman in her late 50s who has fecal incontinence. This is from some focus groups I did with women when I was trying to understand why people might not talk about it with a healthcare provider. But this quote has nothing to do with that. It has to do with not wanting to talk about it with anyone. And what she says is, "The older I get, the more I think maybe I don't ever have to tell my children I could have a stroke or a heart attack. They'll never know, just quietly die." So to think that, our patients, our women and their, perimenopausal, postmenopausal women experiencing these symptoms that are so bothersome that they'd rather die than talk about it with someone. And so perhaps not surprisingly, care seeking for fecal incontinence is pretty uncommon. These again are data from that Mature Women's Health study that we did, when I was a fellow. And less than a third of women with fecal incontinence and just under half of women with urinary incontinence have ever talked about it with a healthcare provider. And when they talk with a healthcare provider, we are on the list for urinary incontinence, but not so much for fecal incontinence. So the physician with whom women most commonly discuss incontinence is their family physician or their primary care physician. And then we're second in line for urinary incontinence. Women are more likely to talk to us than a urologist about urinary incontinence. But when it comes to bowel incontinence, they're most likely to talk to their primary care doctor. The next person in line is gastroenterologist. The next person is an internist. And then we're way down. We're like right there with colorectal surgery. So they're not thinking of us as people that they can talk to about this issue. And this is another quote from those focus groups that I did. This is Wisconsin women with fecal incontinence, trying to understand barriers to help seeking. And this is what a patient said. I did broach the subject with my doctor once, and she wasn't particularly helpful. And each time I have a physical, I think about doing it, and I just haven't done it again because I was unsuccessful the first time. And I think that really, like that quote resonates with me, right? Like none of us want to think that, you know, we kind of flubbed something the first time a patient brought it up, and then every time she sees us, she thinks about it, but she doesn't bring it up because we didn't have the right answer the first time around. So I think it just kind of like is a good reminder of how we have a lot of power, and we can be helpful in these really stigmatized conditions. So also when I first got here, another thing I wanted to understand was what people who were seen as primary care providers felt about screening for urinary and fecal incontinence. And so I did a survey of primary care providers in the UW system. So that was family medicine docs, that was us if we considered ourselves primary care providers, geriatricians, internal medicine. And there were, I believe, I apologize, I didn't review this, but I believe we had about 200 people who responded, 150 people who responded. And what we found was that people thought that screening for both urinary and fecal incontinence was important, but while about a quarter screened most or every patient for urinary incontinence, very few people screened most or every patient for fecal incontinence. And when doctors were asked whether they felt informed to treat patients with fecal incontinence or urinary incontinence, while you can see only less than a quarter felt not at all or slightly informed to treat urinary incontinence. It was about 2/3 who felt not at all or slightly informed to treat fecal incontinence. So we do think this is an important issue, but we don't ask about it, probably mostly because we don't know what to do about it. So why would you ask if you don't know how to help? So so that's my segue into why like this is not a waste of your time talking about fecal incontinence. And you can see the Bucky Badger here, so that means we're hitting an objective. We're going to talk about risk factors. As I mentioned earlier, the greatest risk factor is disorders of chronic bowel disturbance, including having your gallbladder removed, because that can result in a change in your stool consistency. So I had to have my gallbladder removed in March. And I was like, man, after I had my 2 elective C-sections to try to protect my pelvic floor, now I have to have a lap chole. The other risk factors for fecal incontinence include increasing age, urinary incontinence, diabetes, neurologic conditions like having had a prior stroke, having multiple sclerosis, obesity, anoreceptive intercourse, and prior pelvic floor damage from childbirth, surgery, or radiation. And, we are OBGYNs, we take care of women, but in men, the treatment for prostate disease can damage the anal continence mechanisms and is a risk factor. So obstetric risk factors for fecal incontinence are not trivial. These pictures just always make me cringe. Looking at the bowl of muscles of the pelvic floor and the fetal head. Obstetric anal sphincter injury is a risk factor for fecal incontinence, but its impact wanes over time. Operative delivery is another risk factor for fecal incontinence, especially when it occurs in the context of an obstetric anal sphincter injury. But remember that it's also often happening in a setting where somebody's been in labor for a lot of hours, so there's some ischemia to the pelvic floor. So it's really hard to tease out the associations of these things. We don't think that pregnancy or labor in and of itself is a risk factor for fecal incontinence. And the data are becoming more compelling for advanced maternal age and increased infant birth weight as risk factors for fecal incontinence. So there was a meta-analysis, a really elegant meta-analysis that was published just this past March that was looking at the risks, obstetric risk factors and other risk factors associated with postpartum fecal incontinence in the 2 months to 12 years after delivery. And remember, like over time, we end up meeting men in terms of risk factors for fecal incontinence. So these obstetric risk factors are more important in the short term than the long term. But what we see, and so just to orient you, this is a busy slide here. The S column means the number of studies from whom they pooled data to come up with these odds ratios. And the P is the number of participants whose data were pooled. So we're talking about thousands of women whose data were pooled to come up with these odds ratios. So there were the most women and the most studies looking at forceps or vacuum, C-section, maternal age greater than 35, and the risk of spontaneous vaginal delivery. And what we see is that operative vaginal delivery is a risk factor and it maintains statistical significance both in the short and long term. C-section, the confidence interval crosses 1, that means it's not significant. Maternal age greater than 35 is associated with fecal incontinence in both the short and long term postpartum periods. Spontaneous vaginal delivery, probably not. There's one study here where there was an increased risk in the first 2 to 18 months postpartum, but that risk decreases over time with the more studies included. Obstetric anal sphincter injury, probably in the short term, perhaps not in the long term, but that shows us that wide confidence interval means there weren't a lot of people in that included. The other ones that are worth looking at are pre-pregnancy BMI greater than 30 is a risk factor for fecal incontinence in the long-term postpartum. And fecal incontinence in pregnancy is the most important risk factor for fecal incontinence postpartum, which is sort of intuitive, right? But large baby also probably brings an associated risk of fecal incontinence, at least in the short-term postpartum. I don't know what to say about this Pitocin. I would say 4,000 women, like let's withhold judgment here. But that's what that's the current, like that's kind of like the most up-to-date meta-analysis looking at these obstetric risk factors and how they interact with fecal incontinence. So I had to update, I wrote an up-to-date article about management of fecal incontinence during pregnancy, and I just had to like review all my images, so I just stole them for this talk. So these are all taken from up to date. All of these, when you see the little Wolters Kluwer sign, that shows you that's an up to date image. It's not mine. So I'm going to talk a little bit about why fecal incontinence happens and what are the various mechanisms that, when compromised, lead to fecal incontinence. So obviously, there's a bowl of muscles of the pelvic floor and the anal sphincter complex, and those muscles are driven and coordinated by nerves. So there's an internal anal sphincter, which is a smooth muscle under involuntary contraction, which maintains resting anal sphincter tone. And then there's an external anal sphincter, which is one that you can actually squeeze. And so it's striated muscle and it's under voluntary control. And then there's also a bowl of muscles, the puborectalis muscles, that wrap up from the pubic symphysis in the back and circle around the rectum. And when they're functioning well, they make the rectum and the anal canal go in an L shape so that when stool is delivered to the rectum, there's a little bit of a natural barrier here. It's not just a straight line, but you can imagine that if this muscle is relaxed, then there becomes a straight line and stool can slip right out. The rectum itself has to have compliance. It has to have there has to be space in there to receive stool. And it has to be able to expand to receive more, and it has to be able to empty. And then the type and transit rate of stool is also really important, because if you have loose stools, you know that they move faster and they're harder to hold on to. And conversely, if you have like teeny tiny rabbit pellet stools, those do not move quickly, but they do slip out easily because they are less easy to hold on to than a formed stool. And a lot of people don't realize, but if you're very constipated, then the rectum becomes full of stool and then there's nowhere for new stool to come. So you can have sort of like overflow fecal incontinence because of constipation. So I'm going to talk about the recto-anal inhibitory reflex, which makes almost no sense when you, which makes almost no sense. And I feel like contributes to fecal incontinence. So when stool is delivered to the rectum, what naturally happens is that your internal anal sphincter, that like resting tone that you don't think about, that internal anal sphincter relaxes a little bit, and the external anal sphincter should contract at the same time. So like when stool is delivered to your rectum, the internal trapdoor opens. Like that seems a little bit crazy. But the reason why that happens is because the nerves that communicate to the brain what's in the rectum are located in that anal canal. So that allows a sampling process so that if it's gas that distended your rectal wall and you're like alone in your office giving grand rounds, for example, you can just let it out. But if you're in the middle of a patient exam and all of a sudden you perceive that there's liquid stool, you're like, excuse me, I'm going to have to step out, right? Or you feel like there's something delivered to your rectum, it feels like formed stool, you have a little bit more time. So this sampling mechanism, this like seems sort of crazy that this trapdoor opens, but the reason for this mechanism is so that we know what's being delivered to our stool and we can integrate and figure out how to manage it. So ACOG has a practice bulletin about clinical management of fecal incontinence, and this was published in 2015, which is like a huge victory but also kind of shocking, right? Like it took until 2015 for us to have guidelines about how to manage fecal incontinence. So if you take one thing away from this talk today, I want it to be about doing a good rectal exam on a lady with fecal incontinence because you can learn so much. So this image on the right is taken from a New England Journal publication a long time ago now by Arnie Wald, who's a GI doc here. His wife is the chair of pediatrics. So Arnie Wald also has an interest in fecal incontinence. So when you do so most of the time, the most important part of your evaluation of fecal incontinence, other than the history, which we'll get into, is a good rectal exam. So with your gloved index finger, you ask the patient to Valsalva and you insert your finger and just a little bit, and then you ask her to relax. And you can feel the like hug, the circumferential hug around your finger tells you about her internal anal sphincter resting tone. If that's normal, that's a 4 out of 5. If it's tight, if it's squeezing you, that's a 5 out of 5. And that can be, you can get like a hypertonic anal sphincter, which has all sorts of other problems. And we're not talking about that today. But so you have her Valsalva when you insert your gloved finger, because that will also relax the external anal sphincter. So it'll be more comfortable. So then you have her relax, you can feel that resting tone, and then you ask her to squeeze. And you can feel circumferential squeeze around your index finger. Then put your thumb inside the vagina and feel the rectovaginal septum right near the distal vagina. You can feel the muscle of the external anal sphincter. You can feel whether it's intact, whether there's scarring from a prior delivery. When she squeezes, you'll be able to feel muscle fibers squeeze around your index finger, and you'll also be able to feel muscle fibers squeezing under your thumb. And that'll give you a bunch of information. Then you advance a little bit further, feel her pupil rectalis, see whether your fingertip moves when you ask her to do a Kegel squeeze, and you can make sure there's no rectal masses. But a good rectal exam can give you so much information. ACOG recommends that we do proactive screening for fecal incontinence in women with risk factors, including age 50 or older, prior obstetric anal sphincter injury, which I can tell you nobody knows whether they had that. Everybody just knows whether or not they tore and whether or not it took a long time to sew them up. Anoreceptive intercourse, urinary incontinence, or other pelvic floor disorders, chronic diarrhea, diabetes, obesity, or rectal urgency. Not sure how you'd know about rectal urgency unless you asked, but those are the risk factors, and ACOG recommends screening people who have risk factors. So how on earth do you start that conversation? Um, the sort of like, one of the strategies for talking about anything is this normalizing statement at the beginning, like, problems with bowel and bladder control become more common in women after menopause. Tell me how your bowels and bladder are doing. You having any issues with control? How about accidental bowel leaks? Ever lose stool when you don't mean to? Ever have trouble making it to the bathroom in time? Um, One of the ladies who was a participant in the focus groups around barriers to care seeking pointed out how nice it is to have a question about bowel and bladder control on the questionnaire if the doctor makes you fill out a questionnaire when you're in the waiting room, because that survey opens the door. It's easier to walk through an open door than to knock on it yourself. So first of all, I mean, obviously, like, my questionnaire is all about pee and poop and sex, but if there's something checked off, like I have on my review of systems, memory problems. So if they check off that memory problem box, then I can say, "You checked off memory problems here. Tell me a little bit more about that." And I can start to probe for mild cognitive impairment, which is, a similarly stigmatized condition that impacts older women. So if you're not screening for urinary and bowel incontinence on a review of systems, I'd consider adding that. And then that gives an opportunity. It also tells the patient that you're somebody who could help with that, right? Like they can say to you, I saw something about bowel leaks on here. Can you help me with that? Or what can I do about that? I didn't know that was a medical problem. That's another common misconception, is that it's not a medical problem. It's because of something that they did. Oh, I'm going the wrong way. All right. So the cornerstone of evaluation, like anything else, is a good history about the frequency of episodes, how severe they are, whether the patient can identify triggers, how bothered she is, whether she has associated anxiety, and whether or not she's making lifestyle alterations. And then, an abdominal and pelvic exam and a perianal inspection and a digital rectal exam, and a good look at the perineum. Colonoscopy should be like, you should be thinking colonoscopy in these patients. This is a picture of a dovetail sign. So the physical exam findings that you're sort of looking for in a patient with fecal incontinence might be dermatitis around the anal area. A patulous anus would indicate denervation, loss of the anocutaneous reflex. So if you stroke the skin, there's not a little flicker. Weak resting or squeeze tone, anal deformities, excessive perineal descent, prolapsing hemorrhoids or rectal prolapse, so that what's actually happening is that there's mucus or a stool that's on those things that's just hitting the underpants, as opposed to it actually being a problem with the continence mechanism. And then the dovetail sign is the absence of folds. So you can see, like, you usually see these circumferential folds all the way around the anal sphincter. Here, there's a dovetail sign. You lose it up here because this is where the external anal sphincter has been disrupted previously. So this is an algorithm. We published a clinical expert opinion about management of fecal incontinence in the Green Journal last fall. And one of our goals was to just like make a simple algorithm so that, like, if somebody shows up in your office and they have fecal incontinence, here's what you can do about it. First of all, after the patient discloses symptoms, offer reassurance that it's common and treatable, provide information, and then work with her on behavior, like low risk behavioral interventions, dietary and other triggers, skin care and protection, your exam, obviously, and then thinking about red flag symptoms that prompt you to get to refer to GI for colonoscopy. If she's 45 or older and hasn't had a colonoscopy yet, she needs one. So the educational resources that are easy, that I prefer, are the ACOG has a patient education handout about accidental bowel leakage, and so does OGS. And you can get the OGS one for free. You don't have to be an OGS member. You just go to OGS.org and you search for patient leaflets, and you can find this and download it. It's one page front and back. There also are good electronic resources. The National Association for Continence has resources for both women and men. And then the initial behavioral modifications that are recommended are identifying and avoiding triggers. Common triggers are things like dairy, coffee, alcohol, and spicy or fatty foods. And medications that alter stool consistency and are common culprits are laxatives, antibiotics, antacids, NSAIDs, and oral hypoglycemic agents. In terms of skincare, I usually just reinforce the fact that our bottoms are just as sensitive as they were when we were babies in diapers. So, we are very gentle. We dab. We use like alcohol-free wipes with our babies. We use zinc oxide or Desitin or A&D ointment to protect that, use a moisture barrier. So if somebody is suffering with bowel incontinence or bladder incontinence too, skincare is really part of the solution. Butterfly body liners are a nice product that they can buy online. They're thin like a panty liner, but they have like gentle adhesive that adheres to the buttock crease so that, a lot of women with mild bowel leakage tuck toilet paper into their bottom. So this just like stays there. It doesn't migrate and end up coming out your pant leg in 3 hours. So it's a nice option and it helps with light leakage. Um, Once you've done those sort of initial things, you assess stool consistency using a Bristol stool form scale. And you're basically just trying to figure out, is she mostly too firm or too loose? Or does she have appropriate stool consistency? In which case you're moving down to the next line of solutions. Um, the Bristol stool chart just kind of goes from too constipated to too loose. Types 3 and 4 are the ones that we want. Um, and fiber supplement actually can help with both stools that are too firm or stools that are too loose. And the reason why is because fiber has both soluble and insoluble components. And fiber is healthy for you in terms of some other things too, like reducing cholesterol. And so there's kind of like two functions of fiber. There's the short chain fatty acids, which deal with colonic water absorption. And then there's the insoluble fiber, which does the stool bulking, pulls water into the stools and gels the stool consistency together. Fiber increases rectal distension, so it gives you more sensory awareness. It also reduces liquidity of stools and it aids with more complete rectal evacuation. So, um, but there's like a million fibers on the market. So if you're going to take home something in terms of fiber supplementation, it's psyllium. Psyllium is the fiber that's in Metamucil. It's also, you can buy psyllium husk at Trader Joe's if you're like the natural type person. Psyllium also comes in capsules, so you don't have to do powder. You can do capsules. And when in this double-blind randomized trial where they basically put different types of fiber into like a muffin and something else I can't remember, and had patients do it every day for a month, what they found was that the people who got placebo continued to have five episodes of fecal incontinence per week, whereas the people who got psyllium went down to only having about 2 episodes of fecal incontinence a week. So with nothing other than fiber, we cut fecal incontinence episodes in half. Psyllium is the only type of fiber that causes that gelling consistency of the stool, which is important for clumping stools together and helping with evacuation. In terms of medications, loperamide or Imodium is used for folks with loose stools and fecal urgency. Loperamide is more effective and has fewer side effects than Lomotil, which is the other common medication used, antidiarrheal medication used. But in head-to-head trials, loperamide and psyllium perform equally. So that's why I'm like psyllium, psyllium, psyllium. The only problem with psyllium is that you can feel bloated and gassy, so you got to do it really gradually. Like I usually tell my patients to do 1 capsule a day for a week and then 2 capsules a day for a week, whereas like 1 serving is like 5 capsules, but I really go slow because to minimize that. If patients are constipated and you need to help them evacuate, Miralax is the best osmotic laxative to recommend. It's superior to lactulose in terms of all of both in helping people move their bowels as well as abdominal pain and gas. So once you've done what you can do with stool consistency, pelvic floor PT is phenomenal. And you can go right ahead and steal my dot phrase, .gyne PT Madison. I also have got .gyne PT outside Madison if you're seeing somebody who comes from far away, and that just like pulls into your AVS, like the phone numbers that they can call to establish care with a pelvic floor physical therapist. Those folks can help them learn how to coordinate the muscles. They can do biofeedback, which gives you increased awareness of when something is delivered to your rectum so that you can recruit those accessory muscles to help hold on to it. And it's the mainstay of conservative management. Anorectal manometry or endoanal ultrasound are really rarely indicated. And they certainly don't often change management. So that's another thing that I reassure patients is that I'm unlikely to do anything more invasive than a rectal exam in the office. Um, and, this is a picture of an endoanal ultrasound, and you are able to see pretty well the puborectalis, which is the white sort of U-shaped sling, and then the internal anal sphincter is dark, is the black circle, and then the external anal sphincter is the white circle that's further along. So you can see pretty well with a endoanal ultrasound, but truly um, detecting an anal sphincter defect doesn't change our management much. Um, Once you've done stool optimization and pelvic floor PT, next step would be to consider a trial of a vaginal bowel control insert. And that would be when you're bumping them over to us, almost certainly. And if they can't do a vaginal bowel control insert, then we're looking at a sacral neuromodulator or bumping them for more invasive surgical options. This is the pessary for fecal incontinence called the Eclipse. It is a little purple circle that sits inside the vagina, and it has a balloon that blows up and presses against the rectum. And that just that pressure there makes it so the stool can't slip out. The patient has to deflate the balloon when she's ready to have a bowel movement. So there's this little like tic tac looking thing, which is actually a pump that she uses to inflate and deflate the balloon. Um, it's an effective therapy for patients who are successfully fitted, and the major side effect is like spotting, like the normal pessary type things. Um, the mainstay of surgery now is sacral neuromodulation. And it's not complete cure, but most people get significantly better. This is a picture of the old battery that we used to implant. There is now a rechargeable battery that is half this size, it's thinner, and it also can last for up to 15 years. Um, so the so the and you can have an MRI with it. So the InterStim or sacral neuromodulation is the technology is progressing and it's becoming more accessible and reasonable for all different indications. Sphincteroplasty is almost never the solution these days. Um, because it's almost never the problem. As if you look at who gets fecal incontinence, it's not mostly women in their 20s and 30s who just had a baby. Um, if folks have an acute injury and an isolated defect and have symptoms, we should fix it. But if somebody comes in and she's 60 and she's getting fecal incontinence now, it's not her obstetric anal sphincter injury from 30 years ago that is the reason for her fecal incontinence. Um, there's really no role for artificial bowel sphincters. There is a role for colostomy. That's part of the algorithm if patients are severely bothered. And then there's other things in the pipeline, like all sorts of crazy solutions that are being explored. Um, so, I hope that you'll leave this feeling like there are good solutions available. And we're working on it. We're learning more every day. I tried to focus mostly on low, um, the low risk, s- safe things that you can offer to your patients without sending them to us. But if that's too much of a hassle, then just send them to us, and we're happy to do that work with them. Um, I'm going to stop here and close with this quote, which is from one of my patients. I just love it. This is her wish for us. At my annual GYN exam, I would want for the provider to ask about any troubles peeing, urinary, or anal, or ask about my pelvic floor. They could put on a form you fill out. This would be my fantasy doctor. They'd say, is there something you want to talk to me about your health that you never brought up and you're too embarrassed and you want to make another appointment, talk to me about it? That would be my fantasy because I never get to do that. I'm a very shy person. Um, so I would urge you to consider being a fantasy OBGYN. Thank you very much for your attention, and I'm happy to take questions. I think we have a couple minutes.
That was wonderful. Thanks, Heidi. Anyone with any questions, feel free to unmute and go ahead and ask if you want.
This is Ryan. I don't have a question, but I just wanted to say thank you. I thought that was a really fantastic, concise presentation. This is an area that's always hard to ask about, but I do feel a little more well prepared to be able to take somebody to the next step of evaluation and treatment. So thank you so much.
Thank you. That's nice of you to say. It's always a hard talk to give. I'm not going to lie.
Heidi, this is Mary Landry. Thank you so much for the talk. I will say that there's a fair number of elderly people in my life currently who come to me with all kinds of questions asking for solutions and or providers, and I really like that you normalized it back to standard practice of an OBGYN or family physician. My one question is there, and what I find is the challenge is supporting, and what I think about is a little bit more a nursing support model, because like starting cilium, that can get frustrating. There needs to be some follow-up. You can say as the provider, you're going to have 6 weeks of bloating and more gas. Here's how to gradually increase it. But do you foresee the possibility in the UW Health system of potentially having some specialized nursing support to help patients through some of these very simple but yet hard to sustain behavior modifications?
That's actually what our, that's one of the roles of we have 2 fabulous APPs in our practice, and that's one of the things that they do is they set up these regular, like you're going to come in we talk about it like it's a, it's a marathon, not a sprint. You're going to come back and see us every 2 months. We're going to talk about what worked well. We have some like bowel diaries they can record, like people who want to get into the woods, so get into the weeds, we can do that with them. PT also does some of that work with them, and the 2 nutritionists at the DHC also can be really helpful. So we have those supports built in place. It's currently done by our nurse practitioners, not by by a continence nurse. But we are happy to do that work for your patients. So if you bring it, you can absolutely send them our way to do some of that support. Because you're right that it's there's a lot of hand holding. Like I used to like tell people about giving out bowel diaries, but I was like, that's too much time. It does get better over time. It does get better. The cilium effect of bloating and gas is short-lived. Like gradually your body does. I'm sorry, I'm responding to a question in the chat. Your body does get used to it, but it's initially, you've got to be careful. But that's why going slowly, you might not actually even notice a difference. It's really, if you like read the average American gets 11 grams of fiber in our diet, and we're supposed to get 21, well, 25 or to 30. And so really it's about going slowly. But if people read that and they're like, oh my God, I need to take 15 grams of fiber, and they start doing that, that's going to be like a recipe for disaster. So but people do accommodate, and the bloating and gas doesn't happen forever. And it's also not always cilium, like it's often cilium, but it's not always. And so sometimes there's that trial and error of like, okay, let's try benefiber for you. Let's try a different fiber type. I actually got asked about this on my oral boards, how I tell patients to supplement fiber. I was like, really want me to go into it? Here we go. So slow and steady, guys. Those of you who are going to take your oral boards in the next couple of years, you might be examined by a urogyn. All right. In the interest of wellness, Laura, should we say we're done?
I agree. This was excellent. Thank you so much. Really educational for everyone. So have a great rest of your day, everyone. Thank you.
Thank you. Bye, guys.